University Internal Disease Department, and I am also Director of Simulation Center. Today I am going to discuss with you about hypertensive disease. This is very important because this disease have a lot of complications between population. For example, myocardial infarction, stroke, heart failure, kidney failure, and others. And therefore, we have to learn this disease. When we can put diagnosis of arterial hypertension, when in 2 time visits, if patient have systolic blood pressure more than 140 and diastolic blood pressure more than 90, and then we can put hypertensive disease and we can recommend medicines. Classification of arterial blood pressure. There are a lot of types of arterial blood pressure. For example, optimal blood pressure, normal blood pressure, high normal blood pressure, and first, second, and third degree of blood pressure. When we say optimal blood pressure, when in patients systolic blood pressure less than 120, diastolic blood pressure less than 80. And we say normal blood pressure when in patients systolic blood pressure 120 and 129 and diastolic blood pressure 80 and 84. We say high normal blood pressure when systolic blood pressure is 130 and 139 and diastolic blood pressure 85 and 89. First degree blood pressure. This is when systolic blood pressure 140 and 159 and diastolic blood pressure 90 and 99. Second degree of arterial hypertension. This is when systolic blood pressure 160 and 179, diastolic blood pressure 100 and 109. Third degree blood pressure, this is when systolic blood pressure 180 and high and diastolic blood pressure 110 and high. Except this, we have isolated systolic hypertension. Isolated means when systolic blood pressure higher than 140 and diastolic lower than 90. Cardiovascular risk is the risk of death from cardiovascular disease over the next 10 years. To assess risk, it is necessary to determine presence of cardiovascular disease risk factors. Second one, target organ damage. Third one, associated clinical conditions. We have to pay attention to 3 things to determine the risk of disease. Risk factors. Here we can see risk factors for hypertension disease. Men over 50 years, 55 years, women over 65 years. Family history of early cardiovascular disease in women less than 65 years old, in men less than 55 years old, and diabetes mellitus. Plasma pressure for elderly patients more than 60. Hyperlipidemia, cholesterol more than 5 mmol. Low density cholesterol more than 2 mmol. High density cholesterol less than 1 mmol. Hyperglycemia and impaired glucose tolerance. Metabolic syndrome and smoking. They are risk factors. Next one, target organ damage of hypertension. First one, we have to check heart. If patient have left ventricular hypertrophy, we can determine this by ECG or echocardiography. If we see symptoms of left ventricular hypertrophy, this is target organ damage. Second one, vessels. Ultrasound signs of thickening of the arterial wall, intima media, more than 0.9 mm, or atherosclerotic plaques of the Greek vessels. Pulse wave speed from the carotid to the femoral artery more than 12 meters per second. Ankle brachial index less than 0.9. Kidney, microalbuminuria 30 and 300 milligram day. Increase in creatinine level more than 115, 133 in man and 107 or 124 in woman. Glomerular filtration rate less than 60 milliliter per minute. These symptoms that we have, patient have damage of kidney. Next one, brain. This circulatory encephalopathy also means damage of brain. Next one, we have to pay attention to associated clinical conditions. For example, cerebrovascular disease, stroke, myocardial stroke, transient ischemic attack. Next one, heart disease, myocardial infarction, angina pectoris, chronic heart failure. Next one, kidney disease, microalbuminuria, proteinuria, nephropathy, renal failure. Next one, vascular disease, angiopathy, dissecting aortic aneurysm, symptoms of atherosclerosis of peripheral arteries, retinopathy, grade 3rd and 4th, hemorrhages or exudative swelling or the optic nerve nipple. They are associated clinical conditions. We have risk stratification for the development of cardiovascular complications in arterial hypertension. We have 4 degrees of risk. First one, low degree. Second one, moderate degree. Third one, high degree. And next one, very high degree of risk groups. If patient have high normal arterial blood pressure, if patient have 1 or 2 factor risks, this is low group. If patient have with high normal blood pressure, 3 factor risks or organ damage or diabetes mellitus, this is high group risk. If patient have high normal blood pressure and established cardiovascular or renal disease, this is very high group. Next one, arterial hypertension 1st degree. If no risk factors, even we consider this is low risk. Arterial hypertension 1st degree, 1 or 2 factor risk if we find, this is moderate risk. Arterial hypertension 1st degree and 3 factor risk or organ damage or diabetes mellitus, this is high group risk. And 1st degree and established cardiovascular or renal disease, this is very high risk. Arterial hypertension 2nd degree and even patient don't have any risk factors, we say this moderate risk. 1 or 2 factor risks, this is also moderate risk. But when hypertension 2nd degree and 3 or more factor risk or organ damage or diabetes mellitus, this is high risk. When arterial hypertension 2nd degree and if you find cardiovascular disease or renal disease, this is very high risk. Arterial hypertension third degree. Even patient not have any risk factors. This is very high risk group. Third degree, and patient have one or two factor risk factors. This is very high. Third degree. Organ damage and cardiovascular disease or renal disease, if you find, these all very high risk. Now, risk levels for cardiovascular complications of hypertension, low risk. We can see during 10 years, less than 15% patients can have complications. When we say average risk, the risk, moderate risk. During 10 years, next 10 years, 15–20% patients can have complications. When we say high risk, the risk of developing cardiovascular complications of hypertension in the next 10 years is more than 20%. When we say very high risk, complications may be more than in 30% patients during next 10 years. What kind of complications we are saying about? This is first, myocardial infarction, heart failure, kidney failure, stroke, and other complications. Next slide, we have to pay attention to stages of hypertensive disease. First stage, no signs of target organ damage. There are hypertension in patient, but not hypertrophy of left ventricle or other organ damage. Second stage, we can see in patients hypertension, and we can find target organ damage. For example, patient have hypertension, first degree or maybe second degree, and patient can have hypertrophy of left ventricle. Third, stage 3, disease associated with target organ damage. For example, if patient have hypertension disease and stable angina disease, third stage. Next one, algorithm for managing a patient with hypertension depending on the degree of risk. If patient have low risk with lifestyle changes several months, we have to recommend lifestyle changes. In the absence of blood pressure control, we have to recommend them antihypertensive medicines. If patient have moderate risk, we have to recommend lifestyle changes several weeks. In the absence of blood pressure control, we can recommend them antihypertensive medicines. Next one, high risk. If patient have high risk, we have to recommend lifestyle changes, and immediately we have to recommend drug therapy. Antihypertensive medicines we have to recommend at the time. Very high risk also, we have to recommend lifestyle changes plus start drug therapy immediately. What kind of medicines we can recommend if patient have hypertensive disease? There are basically 5 good medicines. This is diuretics, beta blockers, calcium channel blockers, AC inhibitors, angiotensin second receptor blockers. We have to choose medicines from these groups. If it is impossible, then we have to choose from additional groups medicines. Diuretics, okay, next one, diuretics. We can recommend in patients thiazides, for example, hydrochlorothiazides. We can recommend 12.5, 25, 50 milligram, and we can recommend indapamide 1.5, 2.5 mg per day. but they have side effects. When we recommend long time, maybe hypokalemia, and we have to pay attention for this. And patients have, if patients have got diuretics contraindicated. Next one, beta blockers, nebivolol, metoprolol, carvedilol, bisoprolol. It is better to choose these medicines if patients have hypertensive disease, and except this they have stable angina. These medicines very useful for these conditions, but they have side effects also, maybe bradycardia and bronchospasm. If patients have bronchial asthma, we shouldn't recommend beta blockers. Instead of beta blockers, we can recommend calcium channel blockers if patients have an hypertension and bronchial asthma. Next one, AC inhibitors. AC inhibitors dofenapril, perindopril, ramipril, enalapril, and captopril. These medicines also, if they recommend long time, very useful, but they have also side effects like this dry cough. If after recommending these medicines patient have dry cough, we have to stop these medicines. Except dry cough, these medicines have a side effect like hyperkalemia. Therefore, we have to pay attention. When we recommend these medicines, we shouldn't recommend medicines which contains potassium. If patients have cough, we have to stop these medicines. Instead of we recommend, we have to choose medicines from another group. Calcium channel blockers. Calcium channel blockers, amlodipine, lecardipine, lasodipine, nifedipine, and felodipine. These medicines we can recommend 5-10 mg per day, long time. Especially we recommend these medicines when patients have bronchial asthma, because in bronchial asthma we can recommend beta blockers and AC inhibitors. But they have also side effects, maybe tachycardia, maybe vasodilatation. Except these basic medicines, if patients have pregnant patients with hypertension, the first medicines we have to recommend methyl dofa. Except antihypertensive medicines, we have to recommend antiplatelet medicines such as thromboas, cardiomagnil, 50, 75, 100 milligram per day, long time. And we have to check in patients with hypertension the level of cholesterol. If the level of cholesterol high, we have to recommend medicines which decreases the amount of this cholesterol. For example, statins. Statins we have to recommend 6 months or 1 year. This depends on level of cholesterol. Thank you for your attention.